Center. It is without a doubt that the impact of COVID-19 pandemic on the healthcare systems have been profound as healthcare organizations scramble to adjust under the storm and continue to do remarkable work in the face of many unknowns. The Michigan Health and Hospital Association, along with the MHA Keystone Center, will continue to support you throughout this journey by providing you with up-to-date information, resources, advocating on your behalf both at the state and federal level, and connecting you with partners across our state and nation, like the Michigan Value Collaborative, who have developed wonderful resources to help guide you through these unknowns. On behalf of the MHA and the Keystone Center and all of our staff, we thank you from the bottom of our hearts for all that you do every day. Please know that our thoughts are with each of you today and always. Today's webinar is brought to you in partnership with the Michigan Value Collaborative, who will provide you with an overview of the Resource Utilization Report developed to help guide hospital systems in prioritizing surgical services without impacting the care of the remainder of COVID-19 patients. A few housekeeping announcements before we get started. Please note that all lines are muted during the first part of the presentation. For those of you using PC audio, we ask that you please mute your audio throughout the presentation due to additional noise feedback that may occur. Also, we do recommend, if you have access to a phone, to dial in using the phone call option for better audio and the opportunity to join for the discussion and Q&A portion. Lines will be unmuted during the discussion and QA portion. Therefore, we strongly recommend that attendees mute their lines so that we don't get additional feedback if you're not speaking. You're also encouraged to use the question panel on the right side of your screen for questions and comments, especially during the presentation portion. Lastly, this session will be recorded and slides along with the recording will be shared via the MHA Keystone Channel newsletters and website, along with posted on the MVC public website. On this next slide, we have included link to the MHA COVID-19 websites where you will find updates and information on the daily member alerts that the MHA has been sending out since mid-March, keeping our members appraised of all COVID-related happenings each day. And now, without further ado, I would like to welcome Mark Bradshaw and his colleagues from the MVC to share information on the Resource Utilization Report. Mark, please take it away.
Thanks, Eva. So as Eva alluded to, my name is Mark Bradshaw. I'm the Senior Program Manager with the Michigan Value Collaborative. And I'd like to extend my thanks to MHA for hosting us today. We're here to give you a walkthrough of our recent Resource Utilization Report, which was developed in response to the current pandemic. Before walking through this in detail, I'm going to begin by just giving an overview of who the Michigan Value Collaborative is and what we tend to do on a daily basis. So the Michigan Value Collaborative represents a partnership between 87 hospitals and 40 physician organizations from across the state of Michigan. And we are one of 17 collaborative quality initiatives, CQIs, that are fully funded by Blue Cross Blue Shield of Michigan. And in our case, we are housed at the University of Michigan. Our aim is simple. We work tirelessly to improve the health of Michigan through sustainable, high-value healthcare and trying to ensure that people are able to access the right care at the right time at the right cost. And to achieve this aim, we work every day to help members better understand their performance using robust multi-payer data, customized analytics, and at-the-elbow support. And as part of this, we also support a collaborative learning environment to enable providers to learn from one another in a cooperative, non-competitive space. So the broad question, how MVC works, I suppose the easiest way to describe this is to break up our everyday activity into 3 distinct strands. As I mentioned, the MVC Coordinating Centre uses robust multi-payer data to help our members better understand their performance and areas for opportunity. And these data are constructed into, think of it as 30 and 90-day episodes, and we have these for in total 37 medical and surgical conditions which members are able to access through our MVC online registry. We're constantly updating this. At the start of this week, we had a total of 34 service lines, but 3 have been added this week. So we're continually trying to improve both the quantity and the quality of data which is on offer. We assist our members with accessing and utilizing this data, offering the ad hoc analytic support, as I mentioned, and disseminating regular push reports on a variety of conditions, and we send these out monthly throughout the year. This activity is supported in the middle, you'll see there, by a suite of ongoing engagement activities to ultimately provide members with a forum to meet, collaborate, and share best practice. So this includes our collaborative-wide meetings, where we host representative members from our hospitals and POs across the state. We hold 5 regional networking dinners throughout the year, and monthly have virtual work groups and webinar trainings to bring our members up to speed with the data that's available on the online tool. Finally, on the third strand on the right-hand side, as I mentioned, we are one of 17 collaborative quality initiatives. We work very closely with the other 16 in partnership in trying to develop regular push reports and presenting at work groups together. So just to paint an overview of the data sources that we have at hand, as I mentioned, we are committed to increasing and improving the data that is available to aid quality improvement efforts. And as a result of this, the MVC data sources that are available online have grown considerably over the last 6 years. We're now in a position to offer our members data from a variety of payers, including Medicare Fee-for-Service, Blue Cross Blue Shield of Michigan PPO, Blue Care Network, Blue Cross Medicare Advantage PPO, and BCN Medicare Advantage HMO. We are currently in the process of adding Michigan Medicaid data, and once complete, this will bring us to a position where MVC data sources comprise over 80% of Michigan's insured population. So the amount of data is obviously important, but so is the timeliness of the data which we have to hand. Our Blue Cross and BCN data is refreshed on a monthly basis, and as you'll see on the screen, we currently have follow-up data through the end of March 2020 available on the MVC Registry. Medicare data is refreshed on a quarterly basis, and at present we have follow-up data through the end of September 2019. As with all data sources, there's a slight adjudication period, and at the moment we are running at about a 3 to 4 month lag on the Blue Cross and BCN data, with Medicare coming in at about a 9 to 10 month lag. So the question as to what MVC measures. MVC claims are price standardized and risks adjusted into 30 and 90-day episodes for 37 different medical and surgical conditions. Our payments are typically categorized into 4 main categories that you'll see in front of you on the screen: index admission, professional services, post-acute care, and readmissions. These payments are then further subcategorized in order to help hospitals identify potential areas for opportunity. And when I say potential opportunities, I typically mean where hospitals might have higher utilizations than compared with peer hospitals across the state. So we provide this payment and utilization data for the entire episode, but I suppose the big advantage and the unique selling point is in the post-discharge space. What we found over the last 6 years in working closely with our members is that hospitals are often unaware what happens to patients once they leave the 4 walls, once they leave that institution. And to alleviate this, MVC is able to provide information on all post-acute services, including outpatient services and readmissions that may have occurred at a different facility, as I mentioned, within those 30-day and 90-day episodes. So that paints an introduction to MVC and the data that we have to hand and that is available to our members. What we're now going to do is move on and talk about how we've been using this data to support our members during the pandemic. And with that, I'll pass over to one of our analysts, Chelsea Abshire, who's going to take a walk through the methodology of our recent resource utilization report. So over to you, Chelsea.
Thanks, Mark. So as Mark said, I'm Chelsea Abshire. I'm a data analyst with MVC. And in the next few minutes, I will provide some context around the MVC Resource Utilization Report. So this is a new report that we developed throughout March and April in response to COVID-19. As you all know, hospitals have had to drastically reduce elective surgical volume, creating a backlog of elective surgeries that soon will have to start up again. The idea behind the Resource Utilization Report is that we could use MVC claims data to provide a historical look at resource utilization for several common elective procedures to help hospitals both strategize as well as navigate their surgical ramp-up efforts. This report is not intended to be the end-all be-all tool, but it is still helpful for planning purposes to be able to anticipate what resource utilization may look like for a particular procedure. These are the 17 surgical procedures for which we calculated resource utilization metrics. We chose these specific procedures because they were already existing MVC service lines. Now, not all of these procedures are always done on an elective basis. Sometimes these procedures are done in emergency situations, but it can be difficult in claims data to differentiate whether a procedure is elective or emergent. So for the purposes of this report, we just use the already existing MVC service lines. For each procedure, we calculated these 12 metrics. These metrics, we also calculated these metrics for different time windows. So during the index hospitalization, we calculated the proportion that were done inpatient based on how many had a DRG. If they were inpatient, we calculated median length of stay. We also calculated the proportion that went to the ICU or CCU, used blood product, or used a ventilator at any point during their hospitalization. We also looked at where they were discharged to after the index hospitalization. And the 30 days after discharge, we calculated readmission rates and emergency department rates for each procedure. Some of these metrics, like readmission, ED rates, and length of stay, we calculate all the time at MVC. But some, like ICU, CCU utilization, ventilator utilization, and blood product utilization, we had to create new definitions for based on clinical input. So this is the end product. This report represents all MVC hospitals, so statewide data from 2014 to the Q2 of 2019. It represents all payers that we have, so all Blue Cross payers as well as Medicare fee-for-service. So quickly, I'll walk through an example of how you might read this report. So each row is a procedure, and each column is one of the resource metrics that we calculated. So starting from the first, we see CABG is the first procedure listed. So reading across, you'll see that 100% of CABG episodes were done in the inpatient setting with a median inpatient length of stay of 9 days. 98.9% utilized ICU or CCU during their inpatient stay. 10.5% utilized a ventilator during their inpatient stay, and 43.4% utilized some sort of blood product during their inpatient stay. In terms of discharge dispositions, 11.8% were discharged to home, 61.9% were discharged to home health, 15.4% went to a SNF, 7.4% went to inpatient rehab, and 1.3% went to a long-term care facility. In terms of 30 days post-discharge, 10.2% were readmitted, and 26.5% went to the ED. So you can look at the same thing for all of these different procedures and use this to kind of see which procedures utilize more or less resources than others. So now I'll pass it over to Hari Nathan, and he'll give you a closer look at the clinical implications behind some of these metrics.
Hi, my name is Hari Nathan. I'm the director of the Michigan Value Collaborative, and I'm also a surgeon at Michigan Medicine. So the surgical ramp up and starting to clear our backlog of elective cases is something that I'm kind of currently living. I'll just give you a few illustrations of some of the things that Chelsea has already explained. So the graph that you're looking at here compares the inpatient length of stay across the procedures that we looked at. Now, some of these procedures can be done as an outpatient, but these lengths of stay are for the procedures that are actually done as inpatient. And you can see, obviously, that there's significant variation. That's no surprise, but we think that being able to quantify that variation is really important in terms of being able to plan for a surgical ramp up in order to understand how many inpatient bed days are typically going to be associated with doing some of these elective procedures so that they can be put in the queue in the appropriate way, and so that they can kind of be addressed over a course of several months, because it's obviously impractical to try to clear that backlog much quicker than that. Next slide. Similarly, it's rare, for example, for somebody after having a joint replacement or a gastric sleeve procedure to have to go to the ICU, but it's almost universal for patients undergoing cardiac surgery. And again, this is very important to understand. For some of these procedures, a one-night stay in a cardiac surgical intensive care unit is just part of the pathway, and that's fine, can be accounted for in a surgical ramp-up strategy. But for cases where the stay in an ICU is really related more to the development of a postoperative complication or other unanticipated events, it's really important to kind of be able to estimate, well, what's the overall rate of that happening? What's the risk of that happening for this given procedure, so that one can plan appropriately. And of course, the important thing here is to understand at a particular institution how many ICU beds are actually available after accounting for those that may be dedicated to the care of COVID patients. Here at our institution, we continue to have a census of about 60 COVID-19 patients. And so that's probably not going to change in the immediate future, and that needs to be something that's taken into account as these ramp-ups happen. Finally, blood product utilization seemed like it was going to be a really big issue a month or month and a half ago. It's fortunately turned out to be less of a constraint because so many people have risen to the challenge and donated blood. But it's just another example of the type of utilization that we can look at using these data. So again, one can plan appropriately and consider the probability of needing to give 1, 2, or multiple units of blood after a given procedure. So, of course, as Chelsea mentioned, this is not the be-all, end-all, and there's going to be very hospital-specific information and resources that need to be considered. Every hospital's situation is obviously going to be different. Their ability to shift some of these procedures to ambulatory surgery centers or other sites of care is going to be different. Their ICU bed capacity and their COVID-19 census. Those things are all going to vary significantly. And so certainly not suggesting that there's a one-size-fits-all approach, but to that point, these data are available to all Michigan Value Collaborative member hospitals in an individualized fashion so that they can go on our registry and get these metrics for their specific hospital. And of course, as part of a ramp-up strategy, one needs to consider not just the resources that will be utilized with a given procedure, but also why are we doing the procedure? What's the aggressiveness of the underlying disease process or condition? What's the risk to the patient of delay? Are there alternative treatments that can temporize, or are there alternative treatments that can actually be used as a replacement for surgery? And then finally, of course, for patients who are symptomatic, even if their procedure requires a lot of resources, it may be the appropriate thing to do to go ahead and proceed in order to alleviate that suffering. So the website here is our registry, which is run through Arbormetrics and is available to all MVC member hospitals. And if you are at an MVC member hospital and you don't know how to access this, please get in touch with us and we can make sure you are put in touch with the right people at your institution. It's under a tab called Resource Utilization. So thanks very much for the opportunity to present this to you all, and we'd be happy to take any questions.
We have a few questions that came into the questions box. One of the questions is cost/reimbursement data included in this report, or can it be added?
So I can take the question. Cost and reimbursement data are not included in this report right now, but we can calculate things like, average total episode cost. We can look at cost in relation to post-discharge payments and cost in terms of readmissions and things like that. So that's definitely something that could be added in the future.
Thank you. We have another question.
For MVC member hospitals, you are able to access your average episode costs for these procedures. It's just that they're not all included under one tab. But if you wanted to figure out what's your average episode cost for hernia repair, of course, those data are currently available in the registry.
Thank you. So we have another question that came in. When will we be able to get the MVC resource utilization grid you just covered for our individual hospitals?
So I can take this one. The resource grid which was shown as a statewide version, that's available on our website. The individual institution level reports are all live on the MVC registry. If you don't have access to the registry or aren't aware of who has access at your facility, please get in touch with the MVC Coordinating Centre. You'll see our general email address on the screen there, michiganvaluecollaborative@gmail.com. Please feel free to reach out and we can look at getting you access to the MVC registry and enable you to be able to view those institution-specific reports.
A follow-up to that same question, they asked, but not in the grid form, or has that been added?
I can take that question. So currently we don't have it in the grid form, but the grid form is in the works, and we hope to have it live on the registry within the next few weeks.
And just to dovetail onto that, we are working on getting on the registry. There's a few tweaks to iron out. That said, we have worked closely with a number of members so far to provide them hospital-specific reports in a grid format. Again, if it's something that is needed in a timely fashion, reach out and we'll work closely with you to make sure you receive that.
Thank you. We have another question that came in. With the rescission of the governor's executive order on elective procedures beginning May 29th, I assume you still recommend using the evaluation of doing procedures. Is that accurate?
Harry, are you able to speak to that one?
I'm sorry, my audio kind of cut out as you were reading the question. Would you mind just repeating it for me?
Yep, I can. So they were asking in the rescission of the governor's executive order on the elective procedures, they assume you still recommend using this evaluation for doing procedures. Is that accurate?
So I guess I'm not 100% sure I understand the question, but I think what it's getting at is whether we would recommend using these statistics regardless of the timing of when elective surgery is ramped up.
Correct.
And these are, historical averages, so they should be roughly representative of what the resource utilization is going to be, whether that procedure is done next week or next month. I hope that answers the question, but if not, please, maybe clarify in the chat and we can try to answer it.
Naomi, if you would be willing to maybe unmute Laura Apple to see if she needs any additional clarification. Again, we do encourage that you use the Q&A, but we will also gladly unmute lines to be able to vocalize your question. So Laura, can you hear us okay?
I can. So
wonderful. If you
Yeah, I guess the point that what I wanted to ask was that what the Michigan Value Collaborative has worked up is not dependent on whether or not there's an executive order limiting elective procedures. You're saying in a time of what we expect is, I think we're expecting to be in a time of relatively scarce resources for some time to come, and whether there's an executive order in place or not, you would still suggest that people use this information, correct?
Right, so thanks for clarifying that. Right, so the estimates here in terms of resource utilization are based on historical data and should be just as applicable to procedures that are done in the COVID era as those done pre-COVID. Now, exactly how a given institution uses them in terms of how fast they're able to ramp up or which procedures they choose to prioritize, even while recognizing the differences in the resource utilization, is of course an individual decision that has to be made considering the needs of the population that particular institution serves, as well as the resources available at that particular institution. But the numbers themselves should be reflective of what you should expect over the next few months as those procedures are done.
Thank you, Laura, and the MVC team for continuing to clarify and provide that insight. Do we have any additional questions coming through the chat box? Again, Naomi, if you'd like to maybe work on opening up the lines, I know that it's pretty risky getting a lot of background noise, but I just want to make sure everyone has the opportunity to ask the questions they need. And we will monitor the audio portion if we do get extensive feedback.
So all lines have been unmuted. You will just need to unmute yourself if you would like to speak. Sherry Toth, I see that you have your hand raised.
I'm sorry, that was an error. I'm good.
Oh.
Thank you.
We do have a couple minutes remaining. We wanted to kind of keep the webinar short and sweet and provide you with the background on this tool. But certainly feel free to, we're strongly encouraging to ask any questions that you may have for the presenters. We appreciate them making themselves available and sharing this tool freely and widely. I don't see any additional questions in the chat box. Well, I wanted to thank Mark and Chelsea and Hari for and the entire MVC team for developing this resource and making it available. We greatly appreciate also the time that you've dedicated today to bring this and provide additional insights for our hospital members. As a reminder, the recording will be made available and shared widely and also available on the MVC public website. As you saw, the team has shared their contact information. If you need any additional follow-up, please feel free to contact them. You may also go through the Keystone Center at mha.org if you have any questions. So we wanted to thank you again for joining us today. We hope to continue bringing these type of webinars as we find wonderful resources kind of being innovative and developed in the field. And again, we wanted to thank you from the bottom of our hearts for all that you do on the front line. So have a wonderful rest of your day.